Welcome to the lecture on neurologic emergencies. After completion of this chapter and related work, you will understand the significance and characteristics of the following: the anatomy and physiology of the nervous system, the common disease processes, including stroke, seizures, headaches, and ultramentation, assessment and basic care management involving patients with neurologic emergencies, and this will include performing tests for speech, facial movement, and arm movement, and assistance of the ALS provider in managing these neurologic emergencies. The National EMS Education Standard Competencies for Medicine state that the EMT will apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Regarding neurology, you will understand the anatomy, presentations, and management of decreased levels of responsiveness, seizures, and strokes. And you will understand the anatomy, physiology, pathophysiology, assessment, and management of strokes and TIAs, seizures, status epilepticus, and headaches. Stroke is the third leading cause of death in the United States after heart disease and cancer. It is common in geriatric patients, and more men than women have strokes, but strokes are more likely to be fatal in women. Some other contributing factors include family history and race. For example, African Americans, Hispanics, and Asians have a higher risk of stroke. There are revolutionary treatments now available for stroke, and many hospitals are certified as stroke centers. It is important that you recognize rapid transport is vital. Seizures and altered mental status may also occur when there is a disorder of the brain. A seizure may occur as a result of a recent or an old head injury, a brain tumor, a metabolic disorder, or some type of genetic disposition. Altered mental status is common in patients with a wide variety of medical problems, including intoxication, head injury, hypoxia, stroke, metabolic issues as well. And the treatment will vary widely for this. The brain is the body's computer. It controls breathing, speech, and all other body functions. There are three major parts: the brainstem, the cerebellum, and the cerebrum. The cerebrum is the largest part, as you can see here from this picture. The brainstem controls the most basic functions, including breathing, blood pressure, swallowing, and pupil constriction. The cerebellum controls muscle and body coordination, such as walking, riding, picking up objects, or playing the piano. The cerebrum, located above the cerebellum, is divided into the right and left hemispheres. Each controls activities on the opposite side of the body. The front of the cerebrum controls emotion and thought, the middle part controls movement and touch, and the back part processes sight. In most individuals, speech is controlled on the left side of the brain near the middle of the cerebrum. Messages sent to and from the brain travel through the nerves. There are 12 cranial nerves that run directly from the brain to parts of the head, and these cranial nerves involve control of the eyes, the ears, the nose, and the face. The rest of the nerves are joined in the spinal cord and exit the brain through a large opening in the base of the skull called the foramen magnum. At each vertebrae in the neck and back, 2 nerves branch out, and these are called spinal nerves, and they carry signals to and from the body. And you can see those spinal nerves in this video, in this drawing. Many different disorders can cause brain dysfunction and can affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is very sensitive to changes in oxygen, glucose, and temperature. A significant change in any one of these areas will result in a change in the neurologic status of your patient. As a general rule, if a problem is caused mainly by disorders in the heart and lungs, it does affect the entire brain. If the problem is mainly in the brain, it only affects part of the brain. Stroke is a common neurologic condition that is potentially treatable, and other brain disorders include infections and tumors, and these may cause seizures, AMS, and headaches. One of the most common complaints you will hear from your patients in terms of pain is headache. It can be a symptom of another condition, or it can be a neurologic condition on its own. Only a small percentage of headaches are caused by a serious medical condition, and most headaches are harmless and do not require emergency medical care. However, sudden severe headaches require assessment and transport. Also, if you have more than one patient reporting headache along with other signs and symptoms, be suspicious of some type of toxic exposure like carbon monoxide. Tension headaches, migraines, and sinus headaches are the most common types of headaches. These are not medical emergencies. Tension headaches are the most common, and these headaches are caused by muscle contractions in the head and neck and are attributed to stress. The pain is usually described as squeezing, dull, or an ache. Migraines are the second most common type of headache. They are thought to be caused by changes in the blood vessel size in the base of the brain. The pain generally is described as pounding, throbbing, and pulsating, and they are often associated with changes in vision like flashing lights or partial vision loss. The patient will also have nausea and vomiting, and migraines can last for several days. Sinus headaches are caused by pressure that is a result of fluid accumulation in the sinus cavities. Patients may also have cold-like signs and symptoms of nasal congestion, cough, and fever. And generally, pre-hospital emergency care is not required for a sinus headache. Serious conditions that include headache as a symptom are hemorrhagic stroke, brain tumors, and meningitis. You should be concerned if the patient complains of a sudden onset severe headache or a sudden headache that has associated symptoms. You should suspect a stroke in patients with a severe headache, seizures, and altered mentation. And your patient assessment should include asking the patient if he or she has experienced any recent head injury. A cerebrovascular accident, also known as a CVA or a stroke, is an interruption of blood flow to the brain that results in the loss of brain function. Lacking oxygen, the brain cells stop working and begin to die. Once the brain cells die, there is not much that can be done. It may take several hours or more for cell death to occur because small trickles of blood may be keeping those ischemic cells alive at the time. It is important to realize that prompt restoration of blood flow can preserve or restore function to the brain. Remember, just like time is muscle in the heart, time is brain when we talk about the brain. There are two main types of stroke, ischemic and hemorrhagic. You can see the examples here as they're playing in the animation. An ischemic stroke is due to the direct blockage of blood flow through the cerebral arteries. This blockage can be due to thrombosis, where a clot forms at the site, or due to an embolus, where a clot forms in a remote area and then travels to the site of the blockage. In hemorrhagic stroke, the blood vessel ruptures, causing increasing pressure in the brain and subsequent brain damage. Ischemic stroke is the most common, accounts for more than 80% of strokes that we see. It is the result of an embolism or a thrombus, and generally speaking, atherosclerosis in the blood vessels are often the cause. This is a disorder in which calcium and cholesterol build up, forming a plaque inside the walls of the blood vessels. This plaque may obstruct blood flow and interfere with the vessel's ability to dilate. Eventually, it causes complete occlusion of an artery, and even if the blockage in the carotid artery is not complete, smaller pieces of the clot may embolize deep into the brain, heart, or lungs. A cerebral embolism could block blood flow, and symptoms may range from nothing at all to complete paralysis. Hemorrhagic strokes account for 10 to 20% of the strokes that we see. A hemorrhagic stroke results from bleeding inside the brain, and the blood then forms a clot which squeezes the brain tissue next to it. When that tissue is squeezed hard enough, oxygenated blood can't get in and cells will begin to die. People who are at high risk include those experiencing stress or exertion. People at the highest risk are those who have very high blood pressure or long-term elevated blood pressure that has been left untreated. This causes blood vessels in the brain to weaken, and if the vessel ruptures, bleeding in the brain will increase the pressure inside of the skull and the cranium. Cerebral hemorrhages are often fatal, and you should know that an aneurysm is a swelling or enlargement of an artery due to the weakening of the arterial wall. A symptom may be the sudden onset of a severe headache. When a hemorrhagic stroke occurs in an otherwise healthy young person, it is likely caused by a weakness in a blood vessel called a Berry aneurysm. And these patients will also experience a sudden severe headache, and surgical repair may be possible if care is sought for the patient immediately. Transient ischemic attack, or TIA, is a normal process in the body that occurs as a result of a normal process in the body that breaks up a blood clot in the brain. Blood flow is then restored and the patient regains use of the affected body part. However, it is often indicative that the patient has a serious medical condition that may prove to be fatal if left untreated. When stroke symptoms go away on their own in less than 24 hours, the event is called a TIA. Some patients refer to these as mini-strokes. Although many patients with TIAs do well, every TIA should be considered an emergency, as it may be a warning sign of a larger stroke to come. About 1/3 of the patients who have a TIA will experience a stroke soon after, and all patients who are experiencing TIA symptoms should be evaluated by a physician. There are many signs and symptoms of stroke that you need to be aware of. Generally speaking, these include facial drooping, sudden weakness or numbness in the face, arm, leg, or on one side of the body, loss of movement and sensation on one side of the body, lack of muscle coordination called ataxia, sudden vision loss in one eye with blurred and double vision, difficulty swallowing, decreased or increased levels of responsiveness, speech disorders called dysphagia, difficulty expressing thoughts or inability to speak, slurred speech called dysarthria, difficulty understanding others called receptive aphasia, decreased or absent movement in one or more extremities, and sudden severe headaches, sudden loss of balance or trouble walking, confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, and coma. A stroke in the left cerebral hemisphere may cause aphasia, and this is the inability to produce or understand speech. Speech problems may vary widely, and strokes that affect the left side of the brain can also cause paralysis on the right side of the body. If a stroke occurs in the right hemisphere, it will affect the right side of the brain and cause paralysis on the left side of the body. Usually, patients will understand language and be able to speak, but their words may be slurred and hard to understand. Patients may be oblivious to their problem, and this symptom is called neglect. Patients with a problem affecting the back part of the cerebrum may neglect certain parts of their vision. Bleeding into the brain. If a patient is bleeding into the brain, generally speaking, their blood pressure will be very high. This may be the cause of the bleeding, but it may be caused by the bleeding as a compensatory response. Monitoring the blood pressure and watching for a trend of increasing blood pressure is an important sign, and significant drops may occur as the patient's condition gets worse. Some conditions that may look like a stroke. The first one is hypoglycemia, where there's not enough blood glucose. The second is a postictal state, which is the period following a seizure that lasts between 5 and 30 minutes and is characterized by labored respirations and some degree of altered mentation. The third would be subdural or epidural bleeding, which is a collection of blood near the skull that presses on the brain. And you can see the epidural bleed is A at the top of the picture, and the subdural bleed is B. Epidural is on top of the dura, subdural would be below the dura.
911, where's your emergency?
Yeah, it's emergency. The little boy's going to convulsions. Would you come at 3017 North Lewis?
Okay. What is your address there, ma'am?
3017 North Lewis, Del Papa First Avenue Hill.
Okay, what is the phone number you're calling from?
33489. Okay, thank you.
Hold on, ma'am, I need to ask you
Okay.
some questions. Are you with the patient now?
Yeah.
Okay. How old is he?
He don't want to be too.
Okay, is he conscious?
Huh?
Is he conscious?
Well, I don't know. He's jerking.
Okay.
His eyes are open,
All
but
right, ma'am, is he breathing?
yes.
Okay. Has he had more than one seizure in a row?
Huh?
Has he had more than one seizure
I
in a
don't
row?
know. This is my daughter.
Okay. Is he diabetic?
No.
Does he have a history of heart problems?
No? Oh, he's not.
Okay, ma'am, listen to me, okay?
Okay.
Is he an epileptic or ever had a...
No, not no. I'm sorry. Quit.
Okay, has the jerking stopped yet?
Yeah.
Okay, is he breathing now?
Yeah.
Okay, is he breathing regularly?
Yeah.
All right, hold on just a moment. I'm going to get some help started, okay?
Okay. Oh.
Okay, ma'am.
Yeah.
Okay, we do have an ambulance on the way there, okay?
Okay, thank you.
Okay, I need you to stay on the phone, though, okay? I'm going to tell you exactly what to do next.
Okay.
Okay, is he seizing now?
It's like sleep, but he's breathing faster now, I guess.
Okay, is he breathing regularly?
Yeah.
Okay, all right. Okay, make sure that you lay him down and make sure that he's breathing, okay?
Yeah.
Can you turn him gently on his side?
Gently on his side. Okay.
Okay, when he wakes up,
Yeah.
reassure him and tell him not to get up or walk around, okay?
Okay.
All right, hold on for just a second here.
It's going to turn him on his side.
Okay, when he wakes up, just reassure him that help is on the way and don't let him have anything to eat or drink.
Okay.
It might make him sick or cause problems for the doctor.
All right.
Okay, just let him rest in the most comfortable position and wait for help to arrive, all right?
Okay.
I want you to watch him very closely. If he becomes less awake or vomits,
Yeah.
make sure that you turn him on his side and wipe out his mouth.
Okay.
All right? Do you have any family pets?
What?
Do you have any family pets?
Any family what?
Pets? Any pets in the house? Dogs or cats?
Nope.
Okay. All right, is he on any medication?
Well, I think he is. He's on a defibrillator and breather.
Okay. All right, if you have the medications there, just gather them for the paramedics and write down the name and phone number of his doctor if you have that information.
Okay.
All right?
Okay.
Have someone meet the paramedics.
Okay.
If he gets worse in any way, call me back immediately for further instructions.
Will do.
All right.
It's a great 911 call for a seizure, and it just shows how scary these can be. A seizure or a convulsion is a temporary alteration in consciousness. It accounts for up to 30% of EMS calls, and in the United States it is estimated that there are 4 million people with epilepsy. A generalized seizure is formally called a grand mal seizure and is typically characterized by unconsciousness and a generalized severe twitching of all muscles. This type of seizure results from abnormal discharges from large areas of the brain, usually involving both the right and the left hemisphere. A partial seizure begins in one part of the brain and is classified as simple or complex. A simple partial seizure shows no change in the level of consciousness of your patient. However, they may experience numbness, weakness, dizziness, visual changes, or unusual smells and tastes. It may also cause some twitching or brief paralysis. A complex partial seizure, the patient will have an altered mental status and does not interact normally with his or her environment. This results from abnormal discharges from the temporal lobe of the brain, and other characteristics may be lip smacking, eye blinking, and isolated jerking. Patients also may experience uncontrollable fear and perform repetitive physical behaviors. Tonic-Clonic seizures are described and characterized by a sudden loss of consciousness, chaotic muscle movement and tone, and apnea. It is often preceded by an aura. During a tonic-clonic seizure, a patient may exhibit bilateral muscle rigidity, this is the tonic phase, and muscle contraction and relaxation, the clonic phase, and this lasts from 1 to 3 minutes. The patient may also experience tachycardia, hyperventilation, sweating, and intense salivation. Most seizures last 3 to 5 minutes, and a postictal state of 5 to 20 minutes will follow, in which the patient is unresponsive at first and gradually will begin to regain consciousness. In contrast, an absence, or formerly called a petit mal seizure, can last for just seconds, after which the patient fully recovers with only a brief lapse of memory of the event. If a seizure lasts more than 5 minutes, they are likely to progress to status epilepticus. And seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. Some of the common causes of seizures you need to be aware of. Some, such as epilepsy, are congenital, and the patient was born with the condition. Others may be caused by a fever, a structural problem in the brain, or metabolic or chemical problems in the body. As you can see from the chart here on Table 15.1, it discusses the 4 types, including febrile seizures, and some of the common causes of these. So for structural, you'll see tumors, infections, scar tissue, head trauma, and stroke. Metabolic, hypoxia, abnormal blood chemical values, hypoglycemia, poisoning, drug overdose, and sudden withdrawal from alcohol and meds. And then febrile seizures are caused by a high fever. Epileptic seizures generally can be controlled with medications, and they may also be caused by an abnormal area of the brain, such as, like I said, tumors, infections, or scar tissue. We've already talked about this briefly in the previous slide. Seizures from an abnormal metabolic cause result from the changes in blood chemicals, the hypoglycemia, poisons, and drug overdoses, as well as sudden withdrawal from routine heavy alcohol or sedative drug use. Seizures can also result from high fevers, particularly in children, and these are known as febrile seizures. It is important for you to recognize seizure activity. You must recognize it when it is occurring and whether this episode differs from previous ones. The patient may turn cyanotic from a lack of oxygen in the blood, and seizures may prevent the patient from breathing. In a patient with diabetes, the blood glucose value may also drop. You must look at other problems associated with the seizure, such as patients who have fallen during a seizure may have a head injury, and patients having a generalized seizure also may experience incontinence. Once a seizure has stopped, the patient's muscles relax, they become almost flaccid or floppy, and the breathing becomes labored, fast and deep. This breathing pattern helps the body balance the acidity in the bloodstream, and with normal circulation and liver function, the patient will begin to breathe more normally in minutes. In some situations, the postictal state may be characterized by hemiparesis or weakness on one side of the body, which resembles a stroke. It is most commonly characterized by lethargy and confusion, and your patient may be combative and you must be prepared. If the patient's condition does not improve, you should consider other possible underlying conditions like infection and hypoglycemia. The most common type of neurologic emergency that you will encounter is a patient who is experiencing an altered mental status. The patient is not thinking clearly or is incapable of being aroused. Some of the causes include hypoglycemia, hypoxemia, intoxication, drug overdose, unrecognized head injury, brain infection, body temperature abnormality, brain tumor, and overdose and poisoning. In some cases, the patient will be conscious, and in others they may be alert but confused. Patients can have signs and symptoms that mimic stroke and seizures if they are experiencing low blood sugar. In these cases, the patient may have hemiparesis similar to what occurs as a result of a stroke. The principal difference is that a patient who has had a stroke may be alert and attempting to communicate normally, whereas the patient with hypoglycemia almost always has an altered mental status or decreased LOC. Patients with hypoglycemia commonly but not always take medications that lower the blood glucose level. Patients with hypoglycemia will possibly also experience seizures. The mental status of a patient with hypoglycemia is not likely to improve even after several minutes, and you should consider hypoglycemia in a patient who has AMS after an injury such as a motor vehicle crash. Other causes of altered mental status include consideration of the other possibilities become important because a patient with altered mentation may be combative and refuse treatment and transport. In most cases, a patient who appears intoxicated is just that. However, you must consider other problems. Psychological problems and complications of medications are also possible causes. Infections may cause AMS, particularly those involving the brain or the bloodstream. Patient assessment for neurologic emergencies, always the same. Size up the scene, perform a primary assessment, take your history, perform a secondary assessment, and reassess. In some calls to the dispatcher, the description of the patient's signs and symptoms will give you a fairly good idea of what the problem may be. The most significant difference between an AMS and other emergencies is that your patient cannot tell you reliably what is wrong. Do not be distracted by the seriousness of the situation or by frightened family members. Look first for threats to your safety and follow standard precautions. Consider the need for spinal precautions based on dispatch information and your assessment of the scene, and call for additional resources early. Evaluate the mechanism of injury or nature of the illness, and you need to look for clues to help you determine. There are special considerations for a patient with suspected neurologic emergency, and these include an evaluation of potential trauma, indications of a previous medical condition, and evidence of a seizure. Primary assessment. Remember, your first priority is to look for and treat life threats. Perform a rapid scan and form a general impression. Gather information from the scene and note the patient's body position and LOC. You should be able to tell if a seizure is still taking place. Unless you are stationed extremely close to the scene, most seizures will be over by the time you arrive. If the seizure is still occurring, status epilepticus may be present, and be sure you evaluate your patient's neurologic status using the AVPU scale. Stroke patients may have difficulty swallowing and are at risk for choking on their own saliva. You should evaluate the airway of an unresponsive patient to assure that it is patent and maintainable. You should check for foreign body obstruction and assess breathing. All patients with altered mental status, regardless of the cause, should receive high-flow oxygen. Begin by checking for the pulse if the patient is unresponsive. If no pulse is found, immediately begin CPR and attach an AED. If the patient is responsive, determine if the pulse is fast or slow, weak or strong, and evaluate the patient quickly for external bleeding. Make your transport decision. Establish your priorities based on your assessment of the patient's LOC and ABCs. If you suspect the patient is having a stroke, you should rapidly transport to an appropriate facility. Investigate the chief complaint. If the patient is unresponsive, gather any history of the present illness from family and bystanders, and if no one is around, quickly look for explanations for the altered mental status. In a responsive patient, ask him or her what happened. Evaluate the patient's speech. Gather a sample. Remember that time can be critical in a neurologic emergency, and make a special effort to determine the exact time that the patient last appeared to be healthy. Collect or list all medications the patient has taken. Patients who have had a stroke may appear to be unconscious and unable to speak, but they may still be able to hear and understand what's going on. Try to establish effective communication. Your history should reveal if the patient has a history of seizures, and you should find out if this episode differs from previous ones and what medications the patient takes. If the patient does not have a history, a serious condition should be suspected. Secondary assessment. Your assessment should continue with a full body scan. If you suspect your patient is having a stroke, direct particular attention to your neurologic assessment. We perform stroke assessment by utilizing one of two different means, and we can do this very quickly to help rapidly identify stroke in the field. They are the Cincinnati Pre-Hospital Stroke Scale or the Los Angeles Pre-Hospital Stroke Screen. These stroke scales evaluate the face, arms, and speech. To test speech, ask the patient to repeat a simple phrase. To test facial movement, ask the patient to show his or her teeth. To test arm movement, ask the patient to hold both arms in front of his or her body, palms up toward the sky with eyes closed and not move. All patients with an altered mental status should also have a GCS coma score calculated. So here you can see the Cincinnati Pre-Hospital. These are the three things, is facial droop, arm drift, and speech. And Los Angeles looks at age, history, symptoms, baseline, blood glucose, asymmetry, and then, again, arm strength, grip, and facial smile or grimace. Glasgow Coma Scale, please be very intimately familiar with this, and you do need to memorize it. Patients with significant intracranial bleeding may have a great deal of pressure in the skull that is compressing the brain. This slows the pulse and causes respirations to be erratic. Blood pressure is usually high to compensate for poor perfusion in the brain, and changes in pupil size and reactivity indicate significant bleeding and pressure on the brain. If the patient has an altered mental status, you should check the glucose level if you have the equipment available. During most active seizures, it is impossible to evaluate vital signs. Unless the situation is unusual, vital signs in a postictal state will be approximately normal, and sometimes using monitoring devices is the best way to do this. For example, a portable blood glucose monitor to check blood glucose levels and non-invasive blood pressure methods to monitor blood pressure. Reassessment. Focus on reassessing airway, breathing, and circulation, vital signs, and interventions. Patients who have had a stroke can lose their airway or stop breathing without warning. Interventions are based on assessment findings. Some conditions are easier to identify with treatment options that are readily available, such as stroke, seizure, hypoglycemia, and hypoxia. The cause of other neurologic emergencies may not always be obvious to you, and this may make it difficult for you to provide definitive treatment in the field. In most patients with a suspected stroke, physicians in the emergency department need to determine whether there is bleeding in the brain. The only reliable way to tell this is with a CT scan of the head. EMS systems designate specific hospitals for patients who may be having a stroke. You should notify the hospital staff as early as possible if you have a stroke patient. Patients who have had a seizure require definitive evaluation and treatment in the hospital. Supplemental oxygen is always strongly advised. Most seizures will not require a significant amount of intervention on your part. For patients who are having a seizure, protect them from harm, maintain a clear airway by suctioning, and provide oxygen as quickly as possible. If patients are continuing in their seizures, as in status epilepticus, you should suction their airway, provide positive pressure ventilations, transport quickly to the hospital, and meet with ALS if possible. Notify the receiving facility of your patient's chief complaint and your assessment findings. Call a stroke alert to designated stroke centers. Be sure to communicate the time that the patient was last seen healthy and the findings of your neuro exam, and the time you anticipate arriving at the hospital. A key piece of information to document is the time of onset of the patient's signs and symptoms, and document your findings from your stroke scale and the GCS score. And you should describe the seizure activity if known. Emergency medical care. Headaches. Most headaches are harmless and do not require emergency care. You should be concerned if the patient complains of a sudden onset severe headache or a sudden headache with fever, seizures, AMS, or following trauma. Migraines. Always assess the patient for other signs and symptoms that might indicate a more serious condition. Apply high-flow oxygen if tolerated. Provide a darkened and quiet environment, and do not use lights and sirens during transport. Stroke. Support the ABCs and provide rapid transport to a stroke center. The patient may require manual airway positioning, and you should use suction as needed, provide high-flow oxygen, and monitor the patient's oxygen saturation with pulse oximetry. A patient's paralyzed extremities will require protection from harm. You should continuously talk to your patient and inform him or her of what is going on. Thrombolytic therapy, like clot dissolvers, may reverse the signs and symptoms of stroke, and you need to proceed under the assumption that an area of the brain can still be saved. The sooner the treatment is done, the better the patient's prognosis will be. Spend as little time at the scene as possible, and remember, time is brain. Stroke is a true emergency. The patient for seizures may be in a postictal state upon your arrival. Alternatively, they may still be seizing, and you will continue to assess and treat ABCs and try administration of oxygen. It is difficult to safely package a seizure patient for transport. You need to assess for trauma, use spinal precautions if indicated, and never attempt to restrain a patient who is having a seizure. Not every patient who has had a seizure wants to be transported. It is usually in the patient's best interest to be evaluated by a physician. Your goal is to encourage the patient to be seen by a physician and be prepared to discuss the situation with the hospital staff if the patient still refuses transport. Ask yourself the following questions. Is the patient awake and completely oriented after a seizure? Is their GCS 15? Does your assessment reveal no indication of trauma or complications from the seizure? Has the patient ever had a seizure before? Was this seizure the usual seizure in every way, such as length, activity, and recovery time? And is the patient currently being treated with medications and receiving regular evaluations by a physician? Altered mental status. Signs and symptoms vary from simple confusion to coma. Regardless of the signs and symptoms, AMS is always an emergency that requires immediate attention, even if the cause appears to be intoxication or minor head trauma. In summary, the cerebrum, which is the largest part of the brain, is divided into right and left hemispheres, each controlling the opposite side of the body. Different parts of the brain control different functions. The front part of the cerebrum controls thought and emotion, the middle part controls movement and touch, and the back is involved with vision. In most people, speech is controlled on the left side of the brain. Many different disorders can cause brain or other neurologic symptoms. As a general rule, if the problem is primarily in the brain, only part of the brain will be affected. If the problem is in the heart or the lungs, it affects the whole brain. Stroke is a significant brain disorder because it is common and potentially treatable. Seizures and altered mental status are also common, and you must learn to recognize the signs and symptoms of each. Other causes of neurologic dysfunction include coma, infection, and tumors. Strokes occur when part of the blood flow to the brain is suddenly cut off. Within minutes, brain cells begin to die. Signs and symptoms of stroke include receptive and or expressive aphasia, poor articulation caused by neurologic injury called dysarthria, muscle weakness or numbness on one side of the body, facial droop, and sometimes elevated blood pressure. You should always perform at least 3 neurologic tests on patients you suspect of having a stroke. Assess speech, facial movement, and arm movement. In a transient ischemic attack, or TIA, normal body processes break up the blood clot, restoring blood flow and ending the symptoms in less than 24 hours. However, patients who experience a TIA are at a high risk for completed stroke. Because current treatment for stroke must be administered within 1 to 3 hours and preferably within 2, the onset of symptoms to be most effective, you should provide prompt transport. Always notify the hospital as soon as possible that you are bringing in a patient with a possible stroke so that staff can prepare to test and treat the patient without delay. Seizures are characterized by unconsciousness and generalized twitching of all or part of the body. There are 3 types of seizures that you should learn to recognize: generalized, partial, and status epilepticus. Most seizures last between 3 and 5 minutes and are followed by a postictal state in which the patient may be unresponsive, have labored breathing, have hemiparesis, and may be incontinent. It is important for you to recognize signs and symptoms of seizures so that you can provide the emergency department staff with information as you transport the patient. AMS is a common neurologic problem that you will encounter as an EMT. Signs and symptoms vary widely, as do the causes of the condition. Among the most common causes are hypoglycemia, intoxication, drug overdose, and poisoning. And as you assess a patient with AMS, do not always assume intoxication. Hypoglycemia is just as likely the cause. Prompt transport with close monitoring of vital signs en route is indicated. Thanks for listening, and if you have questions, please bring them to class to discuss with your